Hi, I'm JP Rodriguez with Texas Orthopedics here with our Sports Medicine Explained podcast. And I've got Ryan Tibbetts here, my co-host for the show, and we're going to talk today about adhesive capsulitis and frozen shoulder. Ryan, you're the shoulder expert down here in Kyle, and I know that you and I have talked about frozen shoulder before, or adhesive capsulitis, and some of the kind of details of diagnosis and stuff like that. But I think to just start this for the general population who'll be listening to this, what kind of things should people notice that might indicate they have this, and what is it, so that everybody can know?
Sure. Yeah. No, frozen shoulder, for whatever reason, you see a lot of it, and maybe just because of being in a shoulder practice, but it is more common than people realize. Basically, frozen shoulder is you have a trivial insult to your shoulder. Sometimes it's idiopathic, meaning that it happens for whatever reason. Other times it can be after surgery. Typically, we see more idiopathic frozen shoulder that is basically coming on. Patients have trivial injury to the shoulder, develop inflammation, and then that inflammation progresses into more of stiffness and fibrosis, which is what frozen shoulder is called, adhesive capsulitis. And so you see it more commonly in women. We see it more commonly in patients who have autoimmune diabetes and thyroid problems specifically. There's some incidents of frozen shoulder happening after neck surgery, after breast surgery, after cardiac surgery. So there are some other risk factors that you can see this with. And then a second group of frozen shoulder presentation comes after a shoulder surgery, where patients develop stiffness that they can't get over, and end up having to deal with that post-operatively. So,
And the question is, like, can it happen after you just had a bad night of sleep? Is that frozen shoulder, like where you just kind of wake up and you're like, hey, my shoulder feels stiff? Or like, how long does it how long does it have to be before you're like, hey, this is frozen shoulder, I'm not just like woke up, slept on it wrong?
Yeah, no, that's a good question. I mean, if you woke up and your shoulder was sore, no, that would not be frozen shoulder. But you could sleep on your shoulder wrong, and then that shoulder pain progressively worsens and becomes so severe that you eventually lose your range of motion. And so, that is by definition a frozen shoulder is, global loss of range of motion, just not inability to lift your arm up, but inability to rotate, inability to abduct, internally rotate, a global loss of range of motion. And it's a period of time. And I don't know that you can put a timeline on it, but it's going to develop over a 6-week process. It's not going to be you slept on your shoulder wrong and it
Gotcha.
hurts. Like, it's going to take longer.
Right. So then, for our patients out there, when should they be concerned? Because what if we just try to tough it out, if they just try to tough it out with the shoulder and it's a little stiff, but I can still get to work, when should I be concerned to come in and get seen and evaluated, and then what can be done?
Yeah, so I mean, there's a couple of things that I think patients need to know, and I spend a lot of time educating my patients whenever they come in with frozen shoulder. And so the first kind of phase of a frozen shoulder is this hyper-inflammatory phase. So you have this trivial insult to the shoulder's painful, but then it becomes super inflamed and that pain persists. And then after you go through that inflammatory phase, you begin to stiffen or become fibrotic, and you go from the freezing stage, which is the initial one, into the frozen stage, where the shoulder is frozen and fibrotic. Yeah. And that's where things kind of can stretch out and can last a while, is in that fibrotic stage of being just stuck. And I tell patients they can get their arm up, and as long as they're within the range of motion they have, they may be okay. But if they try to push that limit, it's stiff. And then they develop or go into the thawing or remodeling phase. And so the thing with frozen shoulder is that this can go on for 9 to 12 months. And so, my thought on, what if am I concerned I'm getting a frozen shoulder? I think the thing is 4 to 6 weeks of persistent shoulder pain despite activity modifications, lifting precautions, taking anti-inflammatories and or Tylenol, things that you would potentially do for yourself for an injury. at that point, I think it's worth coming in and getting checked out, and
Gotcha.
unless you had a distinct injury that you're concerned about.
Okay.
But slept on the shoulder wrong, shoulder's bothering you, 4 to 6 weeks is going to be the timeline.
Okay. All right. So that's good to know. And then the last thing I was going to, or not the last thing, another thing that I was going to say, when I get patients with this, I'd seen the treatment algorithms kind of change where for a long time it was like, well, injections might not help. This thing's going to kind of work its way through. How effective is physical therapy? And at least for me, as like one of the younger guys taking care of this now, I feel like I've seen, waves of different treatments go in and out of vogue. And, I'm still pretty aggressive with people when they're in that freezing phase like you were talking about.
Mm-hmm.
But what's been your algorithm, recently with all the new developments on when to be aggressive with people, when are you just waiting, and what can people expect when they are in these phases?
So I think kind of literature's shown that you basically want to find or classify these patients into what phase they're dealing with, and then base that treatment off of that. And so, within the first 2, freezing and frozen phase, there's an inflammatory component that I think you need to be pretty aggressive with. And so in that stage, you're talking about regular use of anti-inflammatories if a patient can tolerate it, steroid injections, or an oral like steroid taper.
Gotcha.
And that's all aimed at really reducing that inflammation. Physical therapy, home exercises for stretching is another big thing. I think you have to be careful in the early inflammatory phases of not aggravating that.
Gotcha.
And making that worse. And so that is a little bit of a delicate balance as to trying to determine where those patients are in the process. And sometimes I'll have patients do some more home exercises while we're trying to get the inflammation down, and then get him set up with physical therapy at the appropriate time to try to work on stretching. Now, you move into someone who's been dealing with this for months on end, and maybe they haven't had an injection and tried some things like therapy. You still could consider that, but 9 months, anywhere from 6 to 9 months of failed conservative treatment is where I start talking and thinking about potentially surgical intervention, like a manipulation.
Gotcha.
Or going in with a scope and basically breaking up those adhesions, doing a lysis of adhesions.
Right.
But typically I tell patients at least 6 months, 6 to 9 months, failed conservative treatment prior to even talking about that.
And I think that's really a big deal to kind of get out there so that they can manage their expectations. We talk about this a lot with most of our practice stuff, but just understanding that I think once people know that, hey, this can go 6 months, and then it's just I think there's less anxiety in knowing that, oh, hey, I'm not better yet. And you're like, yeah, that's okay.
Right.
That's okay. But along with that, like, am I not better yet? And the anxiety, I've been kind of moving back and forth when I get an MRI after I've seen somebody. And I had been getting MRIs as early as 6 weeks of good treatment.
Right.
But I've been pushing that back a little more if there's been no real injury. Look and aiming more for like this 3-month mark. When's your threshold on MRIing these people when they've had no trauma?
Yeah, so I kind of fall into the same camp as you. It really goes to history and looking at, has there been an insult or an injury to incite the pain that they're having? If it's very trivial, if I awoke with shoulder pain, it's progressively worsened, now my shoulder is stiff and I can't move it, I push that MRI back because I'm not as concerned about there being, a rotator cuff tear or a labral tear or a biceps labral complex or an instability problem. And so you kind of have to it's patient to patient, but I would say within that probably 6 to 12 weeks, depending upon the patient and how things are. If you get a patient that comes in who meets the typical presentation, it's a female diabetic who has this all of a sudden super painful shoulder that's persisted for 4 to 6 weeks. They come in, they have obvious stiffness and clinical symptoms of adhesive capsulitis on exam. That patient I'm going to wait before I go and get an MRI on. A younger patient who may be on the earlier phase, because I typically see this in females 40 to 60.
Okay.
When I see it in a male, almost every time they're diabetic.
I
And
see.
then that's my clinical practice. I've seen males also come in after cardiac surgery and after neck surgery and have this. But if it's somebody who is on kind of that threshold of risk factor, I might push that MRI a little sooner.
Gotcha. And then, we talked briefly about injections and stuff like that. And, I've been having, just because the current time we're in, I've been less aggressive about injections in general, just because of the, unknown steroid effects on the body's immune system.
Right.
And obviously we tailor that to how severe. But have you noticed, I know that the literature seems to support steroid injections in the right phase. What other things do? You mentioned the steroid pack, but what do you feel about, like, topical anti-inflammatories? Do you think people can get by pretty well and have, without having to do the steroid injection if they're nervous about getting a steroid injection, and they're nervous about an oral steroid?
Sure.
The anti-inflammatories and the creams, have those been working for you? I know I've been doing a lot more of that recently than before.
Yeah, I think, there's multiple things that you can kind of use. It's tricky because steroids in diabetics who you see frozen shoulders with, you really have to be careful. And so, I've tried diluting that steroid injection to try to limit that effect. I've tried Toradol injections before, which is an anti-inflammatory that won't affect that, but then you just kind of have to be careful. And so the topical anti-inflammatories are definitely an adjunct. There's literature out there that I need to explore further. I haven't integrated this into my practice, but shockwave therapy is something that I've heard, there's been some results with that. It's not game changer like the absolute. And then there's also been some things with, other pharmacologic things like calcitonin, which I haven't used. I need to kind of, explore that. So there's definitely some newer things that have come out, but the literature doesn't say that, oh my gosh, that's the best thing ever.
Right, cure necessarily, but
yeah, but I think the key is trying to control inflammation as best you can, whether that be with oral anti-inflammatories, topical anti-inflammatories, steroid injections, and then limit further inflammation with regards to activity modifications. And the biggest component of treating frozen shoulder, and you know this, because is educating the patient.
Right.
And patient education as to what they're dealing with, and understanding the process, and realizing that what is needed of them, because a lot of it is home exercise and stretching and working through it. So it's a very tough thing to try to treat because it can last so long.
Yeah, and that's, to me, it is one of the hardest things for me, because here it is, modern medicine, and we've got all these treatments and answers for all these things. If you tear your labrum, we've got 14 different ways of repairing your labrum, and then here it is, frozen shoulder, which may be one of the most common things we see, and then our biggest intervention is time.
Right.
And the body's natural healing response. So along that lines, I've been, as I think medicine's been changing a little bit lately, and that more people are talking about their diet, nutrition, their overall health status. What would you recommend to people out there who are saying, hey, I might have this a little bit? What is your opinion? And this is just, I know there's not a lot of literature on this, but what's your opinion on some of these, diet modifications and lifestyle modifications? And are these gonna, do you think that people are just making things worse if they try to do any of this kind of stuff?
No, I definitely don't think they're making anything worse. I mean, I definitely think there are some dietary changes you can make to reduce inflammation. Yeah. Now, without getting into all the details of all those different anti-inflammatory diets, I don't know that is going to be like the cure-all.
Right.
But I definitely think that can have, those kind of lifestyle changes can make a big difference.
Yeah. All right. Well, I think we're going to try to wrap it up. I think we just trying to get some information out there on frozen shoulders so that everybody understands that, what to expect, and that communication between us and the patients is
Mhm.
probably the most important thing we try to get across, and that being patient with this, and that it is a very well documented disease, and there's a lot of information, and we know that it does get better. So kind of people being patient with us and working through the process is going to get them to the end there. And that, I mean, the last thing is just kind of that relieving of fear. I don't know if I have anybody who has had like an idiopathic permanent frozen shoulder without arthritis. I've had people with mild stiffness, but nobody who's like permanently frozen.
No, I agree. I mean, in patients who don't have underlying reason for stiffness like arthritis, I would agree that eventually, and literature's shown it can take up to 2 years. It can take longer, but these shoulders do thaw out, and you can regain your motion. It's just the timeline on how long these patients struggle with this, and that's something to remember. I mean, this isn't, lifetime of frozen shoulder.
Exactly. Yeah, it goes away, and if they can just kind of get that anxiety down a little bit, it'll make the process a little bit easier.
Correct.
All right, love it. Well, this is us signing off here at Texas Orthopedics, and thank you for your time, and hopefully that was helpful.